Okay, I think we'll go ahead and get started in the interest of time. And so just a couple of housekeeping items. Thank you to everybody for joining us on the first Foundations Curriculum Series lecture of the new year, and Happy New Year to all of you. If this is your first time, the trainees that are in hemodynamics programs are all panelists. And so for you guys, if you want, don't feel obligated, but if you want, you can turn your camera on so that you can interact with the speaker a little bit more than normal on Zoom sessions. For the rest of the attendees, you are not able to turn on your camera or turn on your audio. So please put any questions that you may have as the lecture is going on in the Q&A box. The chat box sometimes gets filled up, so please avoid the chat box. Go to the Q&A box for those questions so we don't lose them. And then Dr. Chock will let you know if she would like interaction during the lecture or to wait for questions for you panelists after the lecture. Make sure that your microphones are on mute. Jack, thanks. And then if you have a question, then the panelists, the trainees, you can unmute and actually ask that question. You don't have to put it in the Q&A box. So now let me introduce our speaker. So Dr. Valerie Chock is an associate professor of pediatrics at Stanford University. She's the associate director for the neonatal prenatal consultation services at Lucille Packard Children's Hospital and the associate program director for the research neonatology fellowship program. Her research includes investigation of altered hemodynamics and regional tissue oxygenation for infants at high risk for central nervous system injury and for neurodevelopmental impairment. She has expertise developing both clinical and research applications for neonatal NIRS monitoring, including the assessment of neonates with PDA, preterm anemic infants, infants with HIE, and those with congenital heart disease in the perioperative period. So thank you, Dr. Chock, for joining us for this lecture. We look forward to it, and I'll hand the reins over to you.
Thanks so much, Danielle, Dr. Rios, for that really kind introduction. Let me just share my screen so that we can get going. And I appreciate all of you folks attending. I know sometimes it's hard at the beginning of a new year and after the holidays to get back into things. So I really applaud everyone's attendance here today. Please feel free to interrupt at any time with questions, but otherwise I'll be happy to take them at the end. Okay, let's see. I think you folks can see the first title slide. Is that correct?
Yep, you're good.
Okay. Fantastic. All right, so today I am tasked with talking about neurohemodynamics in the care of premature babies. I have nothing to disclose. And as some of you may have seen in terms of the learning objectives, I'm going to focus first on the identification of systemic and cerebral circulatory changes during perinatal transition, and particularly in association with intraventricular hemorrhage. But the majority of my talk is going to focus on understanding the clinical utility and evidence for use of NIRS, or near-infrared spectroscopy, which is my favorite topic, and a great way to monitor changes in cerebral blood flow in the premature baby. Okay, so let's start off to get us going with a little poll question. I think that I'm not sure if Danielle or one of you folks would be operating the polls that I sent over earlier, but this is the question to get us thinking. Approximately 80 to 90% of IVH occurs in the first how many hours after birth? Do you guys have the poll launched?
Valerie, our polls for some reason are not working at the moment, but we'll invite everyone to, in this case, put their answers either into the Q&A and chat, and then Danielle and I will moderate that and come up with the most common answer.
Okay, so I'm sorry, I didn't realize that it wasn't working. So the particular choices that you can think about, 24 hours, 48 hours, 72 hours, or the first 168 hours, which is 7 days after birth. When do you think most of the majority of IVH occurs? We'll give people a little bit of time to put their answer into the chat. Danny, let me know when you start seeing
Yeah, I'd
enough.
say we've had about 20 or so responses, and about 80% are saying 72 hours, and there's a few saying 24 and a few saying 48 hours.
Great. Okay. So, oopsie, you guys are correct. Per the literature, the majority of IVH does occur in the first 72 hours of life. And this is relevant because I'll be talking about a few studies that utilize 72 hours as the monitoring period, looking at cerebral oxygenation. And this is part of the reason why. But also keep in mind that most IVH that does happen will extend in the first week of life. So some would argue that even in the first 7 days or week of life, it's important to have a way to assess cerebral blood flow or cerebral oxygenation. Okay, great. So here's a little diagram I put together about how hemodynamic instability and altered cerebral blood flow may lead to IVH. Probably one of the most important concepts is impaired cerebral autoregulation. And we'll go over that again in a little bit, but in a nutshell, it's just basically the brain's innate way of maintaining stable cerebral blood flow despite fluctuations in systemic blood flow. So factors like prematurity, hypoxic injury, growth restriction, and sepsis, which are very common in the preterm population, can in fact even worsen impairment of cerebral autoregulation. Also, we have to consider blood pressure instability as leading to altered cerebral blood flow. So kind of rhetorical question, how many of us really know what blood pressure to treat in a preterm baby? What is your threshold for treating hypotension? Is it mean arterial pressure that matches gestational age? Is it something like 30 millimeters of mercury? I think we'd get a wide range of responses. And really just thinking about it, that our clinical response to what we consider to be low blood pressure, so things like volume expansion, initiating pressor support, that can in and of itself alter cerebral blood flow. So perhaps we are doing more harm than good by treating a random blood pressure number. Of course, one of my other favorite topics is the PDA. And so we do know as PVR drops, so right to left shunting through the duct turns into left to right shunting. And so these changes in ductal shunting patterns can contribute as well to altered cerebral blood flow. Then we have the concept of impaired venous return and elevated central venous pressure. So this can be exacerbated by bedside procedures that go on during the transition period. So babies being intubated, umbilical lines being placed with flushes, surfactant administration, underlying changes in lung compliance and intrathoracic pressure, as happens with as we're altering mechanical ventilation, or just intrinsically with RDS. All of these can contribute to impaired venous return and poor venous drainage, again leading to altered cerebral blood flow in a preterm baby. And then lastly, I'd like to bring up the concept of cerebral ischemia and reperfusion. So this is really driven by hypoxia, hypocarbia, which, as you know, contributes to cerebral vasoconstriction, and hypercarbia, which can lead to cerebral vasodilation. So all these factors can really lead to just changes in your cerebral blood flow together in a preterm baby. And it's just a nice way to sort of think about how babies are set up for something like IVH. Okay. Okay, so this is just our usual slide to remind us of the concept of impaired cerebral autoregulation. And as you recall, in adults and older children, there is a much longer plateau phase or range where cerebral blood flow is kept constant despite changes in the mean arterial blood pressure. In a neonate, that flat range of stable cerebral blood flow is much narrower and almost non-existent in the preterm baby. So in these preterm babies, changes in the mean blood pressure, the mean systemic blood pressure, can get transmitted directly to the brain. Another way to look at this is using the technique of near-infrared spectroscopy. So, you can measure cerebral blood flow by inserting a catheter into the brain, but that's not very feasible at the bedside. So you can get an indirect measurement of cerebral blood flow by measuring cerebral oxygenation. And this isn't just an example from some of the NIRS work I've done. This is actually in a cardiac baby, but the concept is the same. So in red here, you see the systemic blood pressure fluctuating. And in blue, the cerebral saturation remains relatively constant. So this is what you want to see when there's intact cerebral autoregulation. In a baby, however, with impaired autoregulation, you can see here in this tracing on the right-hand side, the fluctuations in mean arterial blood pressure are reflected directly to the brain by similar fluctuations in cerebral saturation. So this baby has impaired cerebral autoregulation. Okay, so this kind of brings us to what neuromonitoring techniques are available to assess hemodynamic changes to the brain. I think many people in this group are very familiar with transcranial Doppler ultrasound, where you place a transducer over the anterior fontanelle. Sometimes people use the temporal window, but basically to interrogate the anterior cerebral artery or the middle cerebral artery to measure cerebral blood flow velocity, as well as resistive indices. This technique is great for a moment in time picture of what's going on with cerebral blood flow, as well as structurally for those that are interested in that. But there are also limitations. For example, the angle of inclination can be different depending on the provider who's holding the probe. There are issues. People tend to like to use probe fixation for longer periods of monitoring, but there are issues with keeping the probe fixed in a stable position. It's really not that feasible for very long periods of time, certainly not over the first 72 hours or the first week of life. And then probably most importantly, literature shows that really cerebral blood flow velocity and resistive index inconsistently correlates with adverse outcomes. So we can't reliably use these measures to tell us which babies are at highest risk for adverse outcomes. But like I said, in and of itself, I think it's a great way to take a picture of the brain and cerebral blood flow in a moment in time. But what about other neuromonitoring methods that we have? I think many of us also use AEEG or EEG, which is fantastic because we know that decreased cerebral electrical activity can be seen during cerebral hypoperfusion because oxygen is required to maintain transmembrane ion gradients. So you are going to see some suppression of the cerebral electrical activity when you have decreased brain blood flow. The problem, though, is that in preterm babies, suppression of brain function may be more subtle because, as you recall, it's very common for preterm babies to have a discontinuous normal voltage tracing to begin with because EEG patterns are still very immature. So it may be more challenging to see these subtle changes that occur from an electrical standpoint when you have decreased cerebral blood flow. So of course, since I'm giving this talk, we know that the focus is going to be on near-infrared spectroscopy as a technology modality to really be most effective at bedside monitoring of cerebral blood flow. And it is commonly used as a trend monitor, as a continuous bedside measure, but there also has been a lot of work looking at threshold cerebral hypoxia measures that I'm going to be talking about next and really focusing on for the rest of the talk. Guys, let me know if there are any questions that are coming up because I'm happy to stop at any time. Okay, so this brings us again to a quick review of how NIRS works. Many of you have seen these slides or are very familiar with it, but NIRS, or near-infrared spectroscopy, it's a continuous, real-time, non-invasive measure of regional tissue oxygenation, often abbreviated RSO2. This technology has been validated with jugular venous sats and has been FDA approved for use in babies, including those preemies or those infants less than 2.5 kilos. At our institution, we routinely monitor even our 23, 24 weekers in the first week of life with NIRS, and have no issues with that, other than the caveat of saying we have to be very careful about skin protection and using a skin dressing. We use Mepitel dressings to protect the skin in our preterm babies. Just a review about how NIRS works. Excuse me, it's very similar in principle to a pulse oximeter. A sensor is placed on a baby's skin, and light passes through from the near-infrared light source on the sensor itself, through the underlying skin, through the bone, into the soft tissue, at a depth of about 1.5 to 2 centimeters, where the light is then absorbed by oxygenated and deoxygenated hemoglobin in the underlying tissue. And then light is reflected back and to the detectors on that same sensor. And a tissue oxygen saturation ratio is calculated. It's heavily venous weighted, so 25% arterial, 75% venous, and reflects the balance between oxygen delivery and consumption in that underlying tissue. So there's a lot of different commercially available NIRS devices that may have slight differences in the number of wavelengths of light, number of detectors to increase precision, but they all work by the same principle. Here's just an example of the sensors on a baby. Cerebral sensor, as you can see here, in a baby's forehead. Some people advocate using only the left side or the right side. In a preterm baby, it's difficult to achieve that because of real estate issues. So we just try to keep our forehead in general as much as possible. We always advocate using 2-site NIRS monitoring because we know that circulatory impairment is going to reduce a somatic saturation site first, which is not as well autoregulated as the brain. And so it's an earlier indicator of hemodynamic compromise using a second site, not cerebral, but in our case, we tend to go with a renal or flank location for the sensor here, which is shown below the costal margin and above the iliac crest. I know some other centers like to use mesenteric saturation monitoring. Some people use peripheral muscle monitoring. For our purposes, we're not going to really talk about that, but for we tend to like the renal saturation in conjunction with cerebral sats. So this next brings us to talking about cerebral hypoxia thresholds. And this is the very common graphic that I show a lot of the time from a large European study with population-based norms. So what's considered to be a safe zone for cerebral saturation is shown here in green. So that's usually between 55 to 85%. And that green zone represents 2 standard deviations of population mean values from the study of preemies less than 32 weeks gestation. So it's a good starting point. When the cerebral sats fall into the 50% below range is when people start getting concerned because it's outside of the normal population range. Keep in mind that this range is typically higher in term babies than preterm babies, and that values can differ based on the sensor and device type, with neonatal sensors typically reading about 10% higher, particularly in the higher range of cerebral saturations. And the trend over time for an individual may be more important than the absolute value itself. But I'm going to tell you next about some other studies that have really kind of validated why this is the danger zone, kind of in this less than 50-55% range. So when we look at cellular evidence, this comes from an animal model. It's a piglet study where piglet cerebral saturation values were held at lower ranges for at least 30 minutes. And you can see here that in the animals where the cerebral saturation was kept over 60%, they had normal tissue structure. So these are histologic images of the hippocampus. But when the cerebral saturation started dropping to 40 to 50%, you start seeing mitochondrial changes. Less than 40%, you start seeing some swelling of the Golgi and endoplasmic reticulum, and then even lower, some fragmentation and absence in these histologic sections. So again, just the histologic evidence that low cerebral oxygenation can cause cellular injury. So what about neuroimaging evidence? So the study on the left side of your screen looks at a population of babies with hypoplastic left heart syndrome. And we can see that in this group of babies, cerebral saturation that were held less than 45% for a cumulative time period of over 180 minutes, these babies develop changes in the periventricular white matter, which is characteristic of ischemia from hypoperfusion. So this is some MRI evidence of this low cerebral saturation threshold around 45%. We did our own study looking at the preemie population. And this was the early NIRS study that I led with a group of others. So there's a multi-center group where we looked at mean cerebral oxygen saturation levels in the first 96 hours of life in preterm babies who are very low birth weight. And what we found was that those who had adverse outcomes, those who died or had severe IVH, shown here on the right-hand side, had lower mean cerebral oxygen saturation levels. And in fact, when we looked at the threshold level, the percent time with the cerebral saturation less than 50% was associated with adverse outcome, with a pretty good area under the curve. So this, again, kind of points to, just even based on outcomes and specifically imaging outcomes of IVH, that this saturation threshold about 50% is where we need to start being concerned. This was a study of about 103 babies. And then, so finally, what about neural development? If we go back to the hypoplastic left heart syndrome population, George Hoffman's group looked at abnormal visual motor integration at 56 months. And what they found in their cardiac patients was that if the cerebral saturation, the RSO2, was less than 45%, so shown here, for at least an hour, these are the kids who at 56 months of age had abnormal visual motor integration. If we go back to our preemie population, this is a large study by the Dutch group, 734 babies. When they looked at the outcome of death or poor cognitive outcome at 24 months, and this was using the Bailey-III exam, you can see that these are kids that had lower cerebral saturations in the 72 hours after birth. They were more likely to have adverse outcomes, and the threshold that they found was a cerebral saturation of less than 55% for at least 20% of the time. So again, in general, this sort of 45-55% range, we need to be concerned from cellular evidence, radiographic evidence, neurodevelopmental evidence. But of course, you can come to me and say, all of these are observational studies, and it implicates the cerebral hypoxia threshold. But what about the interventional trials? What about the highest evidence randomized controlled trials? So I'm going to talk briefly about the SAFE-BOOST study, which I think if anyone is familiar with, is one of the primary trials that was done with NIRS work. And this study was looking at maintaining a targeted range of cerebral saturations using a treatment guideline, with the idea that this might improve outcomes. This was a large European study, and the SAFE-BOOST 2 group, as I said, targeted cerebral saturation between 55 to 85% in the first 72 hours of life. So this period of transition in the premature baby. And they compared this group of babies that had this intervention to keep cerebral sats between 55 to 85% compared to standard of care control group. And they're looking at, first of all, this graph shows the burden of cerebral hypoxia or hyperoxia. So this is defined as the time outside of range, so either below 55% or above 85%. And it's reflected not only the duration of time the baby was out of range, but also how far away from target range that baby was. And what you can see here is that the interventional group had a lower burden of cerebral hypoxia or hyperoxia at 36.1% hours compared to the control group at 81.3% hours. This difference was mainly driven by a reduction in cerebral hypoxia. So the study itself demonstrated the feasibility of interventions to maintain the cerebral saturation in a targeted range. Now, excuse me, keep in mind that this study was not powered for differences in clinical outcomes, and that was the main criticism. However, they did find a trend towards decreased mortality and severe brain injury. In a few post hoc analyses that were published, it was also found that a high burden of cerebral hypoxia was associated with severe IVH and EEG suppression. And they looked at neurodevelopment at 2 years of age. But as you can see from the graph here, there is really no difference for infants with a low burden of hypoxia versus a high burden. So you can see these black dots are those babies that had a low burden of hypoxia compared to the white dots, which are the kids had a high burden of hypoxia. And this is defined by highest quartile. So they divided the population into quartiles of total burden of hypoxia. But you can see, looking at their Bailey scores and the mental developmental index, really no difference between the black and white dots. So unfortunately, this post-hoc analysis did not find any changes in neural development. So I will mention that the larger SafeBoost C3 trial was completed, and some of you may be a part of groups that have participated in that. And that trial was powered for mortality and cranial ultrasound abnormalities. I'm not going to talk about that because it's still pending publication. I believe it should be coming out soon in New England Journal, but that was an international pragmatic trial powered for these clinical outcomes. I think still, though, that there is room to look at maybe on a more granular level, what does maintaining a targeted range of cerebral saturations entail, especially the interventions that we need to consider. So as part of that, our group, together with Zach Vasolis out of St. Louis, is leading an ongoing trial known as the Brain Oxygenation or BOX trial. And there's various iterations of this, but it's currently a multi-center study looking at, again, the extremely preterm group of babies using NIRS in the first 72 hours of life to maintain target saturations. And we're focusing really on looking at the specific type of brain injury on MRI, looking at specific interventions for cerebral hypoxia, and the relationship with systemic SATs. So just to kind of give you a little flavor of this, because this will lead into the next part of my talk. This is the treatment algorithm that we put together for the ongoing Box 2 study. So we look at things like hypocarbia, hypoxia, hypotension, anemia, the presence of a PDA or IVH, as far as what we can do to keep the target SATs back into a targeted range between this 55 to 85% range. And if we fall outside of range, potentially making some changes in these different variables, it would be important. So I'm not going to spend too much time on that because this brings us very nicely to the next part of the talk about how do you approach abnormal cerebral oxygenation. Again, a review for many of you, but I think it's always important to think about the variables that affect cerebral blood flow and cerebral oxygenation. So I tell people to remember 4 main physiologic variables if they can't remember anything else from this talk. So if you're a provider and you get called to the bedside and your cerebral SAT, the baby's cerebral SAT or RSO2 is less than 50%, what do? Well, you think about a few things. Is the baby overall hypoxic? So if the baby's systemic saturation is low, is this someone who you would need to turn up the FiO2 on the ventilator or improve the baby's overall systemic oxygenation? Second, think about cardiac output, and blood pressure may be a surrogate of that. So is the baby hypotensive? Is this a child that could benefit from starting a pressor or giving a bolus? Thirdly, oxygen carrying capacity. So is the baby anemic? Could this baby benefit from a blood transfusion? And then number 4, the last thing people tend to forget is the really profound effect of carbon dioxide on the brain, particularly hypocarbia leading to cerebral vasoconstriction. So is the baby overventilated? Do we need to make some changes to bring that CO2 level back into range and thereby improve our cerebral saturation? So again, those are the 4 main variables to consider when you go to the bedside. There are also a few other conditions to consider. As I said earlier, cerebral saturation is affected not only by oxygen delivery, but also oxygen consumption. So perhaps the cerebral metabolic rate is something to consider. So for example, issues of sedation or controlling hyperthermia. And then lastly, other underlying conditions. So maybe this baby has a severe IVH. Maybe this baby has a hemodynamically significant PDA with impaired autoregulation, or maybe this baby has congenital heart disease that wasn't diagnosed prenatally. So all of these underlying conditions can lead to low cerebral saturation levels. On the flip side of the coin, you could have cerebral saturation levels that are too high, so over that 85 to 90% range, in which case you have to think kind of the opposite of what we previously did for low cerebral sats. So maybe our arterial sats are super normal, and maybe we can afford to wean the FiO2 on this kid. Similarly, the effect of hypercarbia as a potent cerebral vasodilator, perhaps that can be adjusted, and this baby needs increased ventilator support to bring our CO2 levels down. Baby could not be extracting oxygen. So maybe we need to wean the sedation, check if baby is hypothermic, or in kids with HIE, this could also be a poor prognosis. And then lastly, conditions. There are underlying conditions that redistribute blood flow to the brain. So babies that are growth restricted may have higher cerebral saturations, or babies that are hypoglycemic, since glucose is the primary fuel of the brain. Okay. So this brings us to the little example to kind of just review these concepts. I guess if the polls are not working, I'll just kind of talk about it out loud, and we can put your answer into the chat. But
the polls are now working.
Yeah.
Oh, fantastic. Okay, well, before you launch it, let me just read the question. So here is a preterm baby. Let's say he's a 26-weeker, and he's 1 week old. And you see this sudden drop in cerebral saturation here in blue, where the cerebral saturation dropped from 70% down to 40%. And so you're called to the bedside. And what are some possible things that could have occurred in this baby? And you have to think about what impacts cerebral oxygenation. So if you want to launch the poll now, we can show the different choices. So again, what may have caused the sudden drop in cerebral saturation in this baby? Could it be accidental extubation with severe prolonged DSAT, a hypotensive episode because of problems with, say, your dopamine infusion? Could it be prolonged hypocarbia from overventilation? Could this be a pulmonary hemorrhage? Or could it be all of the above? So if you guys can take a few seconds to enter your guess or choice. And maybe take another 5 seconds, put in your final answer, and we can see what people think. All right. Well, of course, I'm not a good question writer because, of course, you know the answer is going to be all of the above. But it does really illustrate the nice way of thinking about cerebral oxygenation and what are the physiologic factors that can affect it. So it could be because of systemic hypoxia if the baby self-extubated. It could be due to low cardiac output and hypotension from someone changing out the dopamine syringe. It could be from a hypocarbia from an overventilated baby. In this case, in particular, it really was pulmonary hemorrhage. So what we did here, it's shown at the arrow, we transfused some packed red blood cells, and the cerebral sats came up nicely. But you guys hit the nail on the head. All of these potential scenarios could have led to this change and this drop in the cerebral saturation. Okay, great. So I'm going to finish up now. I'm talking a little bit more about the specific use of NIRS in the preterm baby, particularly for conditions of IVH and PDA. Okay, so here's a 26-weeker, 2 days old. And here you see this trace thing where the renal saturation's in red and the cerebral saturation is here in blue. And what do we notice? Well, from what I told you, look at this range of cerebral sats. It's in the maybe 45% range, and then starts dropping lower. So what are some things that you want to know about this baby? Well, again, going over all the physiologic variables that can affect cerebral sats. What's your systemic sats? In this kid, it was 90 to 95%, so that seems reasonable. You probably want to ask me, well, what's the blood pressure? Okay, the mean arterial pressure is 33 millimeters mercury. Again, seems to be an appropriate range for this preterm baby on day 2 of life. What about the CO2? Okay, 48. Again, that seems reasonable, not too low. Hematocrit was 45%, so this child is not overly anemic. So those 4 main variables were actually appropriate in this baby. So now we have to start thinking about other things that could be affecting cerebral sats. So the baby wasn't overly agitated or hyperthermic, so it was not an issue of increased metabolic rate or oxygen consumption. What about a PDA? So day of life 2, most likely this child does have an open ductus. But what's unusual is the cerebral sat is much lower than the renal sat. So why is that brain saturation more severely affected? So what I didn't tell you is this baby also had a mom who was treated for chorio, and the baby is currently being treated for sepsis. We know that chorio is a known risk factor for white matter abnormalities and impaired autoregulation. So we know this baby is at baseline at risk for brain injury. So the low cerebral sat in this particular case prompted a cranial ultrasound on day 2 of life. And unfortunately, it was discovered that this baby had a bilateral grade 3 bleed. It was an unfortunate occurrence, but the discovery of this event was hastened because of the low NIRS values being seen. And here's a picture of the bleed. So again, just part of the reason why we monitor preemies in the first 7 days of life with NIRS is because of the highest risk for IVH as well as extension of bleeding. So Gabriel Altit and his group, and with our group as well, conducted a study where we found that cerebral saturation was associated with anterior cerebral artery Doppler measurements, and lower cerebral sats were found in preemies with severe IVH compared to those without IVH. And so in babies with IVH, the low cerebral sats could be due to excess venous blood in the area of hemorrhage, or a lower cerebral blood flow state to begin with. What we are unclear about is, can we catch this time period of hyperperfusion and impaired autoregulation before the baby even bleeds and actually prevent the bleeding from occurring? So that would be a goal for future research. And I know that there's some current work with looking at real-time measures of cerebral autoregulation, how that can be displayed on the NIRS monitor. That's something that's ongoing right now, and that might help us in the future to avoid IVH from even occurring. So here's an example that I also show a lot. Just another example of a 24-weeker. This was a triplet. She had bilateral grade 4 IVH and ventriculomegaly. And what do we notice here on the screenshot? The cerebral saturations in blue are extremely low. They're ranging from 15 to 50%. 15 is the lowest that's readable on an INVOS monitor. So prolonged periods of time where the cerebral saturation was less than 40%. The corresponding AEG tracing showed a discontinuous low voltage tracing. And here at the arrow, transfusing packed red blood cells finally allowed the cerebral saturation tracing to even barely pick up transiently. So in this case, the family ended up withdrawing intensive care support. But I think having the NIRS monitor at the bedside really helped to assist with end-of-life discussions, because there are some families and parents that are very visual and can kind of see, like, look, your baby's cerebral oxygen levels are not even picking up or are extremely low. This does not, portend well for a baby's overall brain oxygen and long-term neurodevelopment. So just, another example of how cerebral saturation is very low with IVH and how it can help with neuromonitoring. Okay, I think we'll shift gears now to our last topic of the patent ductus arteriosus. Again, one of my other favorite topics. So as you guys all know, the PDA is very common in extremely preterm babies, and NIRS has been used to study the cerebral and somatic effects of the duct as well as response to treatment. So how do we predict what is a significant PDA? So we did a study at Stanford where we looked at cerebral and renal sats for all babies less than 29 weeks gestation. And what we found was that those babies that had a significant PDA, as defined by echo characteristics, had lower renal saturations compared to those babies with no PDA on echo or no echo done at all because of low suspicion for a duct. Their cerebral sats were also lower, although not statistically significant. So this could be due to maybe some preserved cerebral autoregulation. And as I mentioned earlier, the somatic site, so in this case, the renal site, will see changes first. So that's why I believe that for this particular study, we found that low renal sats were what were particularly associated with a significant duct. We looked at this, this is the RLC curve, and we found a threshold of the renal sat of 66% being associated with a significant PDA with pretty good sensitivity and specificity. Okay, so let's look at this other case example. This is a 24-week gestation preterm baby, 3 weeks of age, with concern for a significant PDA. Actually, I think this is the last poll question that I have. Looking at this tracing here, where you can see the cerebral saturation in blue and the renal saturation in red, and a subcostal view on echo, maybe you guys can launch the poll and we can just ask the question to the group of whether or not this PDA should be treated. It's kind of a loaded question, but feel free to, take a guess of, would you treat this PDA? Yes or no? Okay, let's close the poll in a few seconds so people put in their final response. Nice, okay. The majority of people would treat this PDA. I would agree with that, although I know there is definitely room for discussion. But the reason why I would agree that this is a significant PDA is that here you see, as I mentioned, the renal saturation in red, being quite variable and low, sometimes going, dipping as low as the 30 to 40% range. Cerebral saturations do seem okay in particular, but also looking at the echo, you can see reversal of diastolic flow in the descending aorta shown by these asterisks. So this kind of slightly lower cerebral saturation, the significant variability in the renal sats and lower renal sats, and the echo findings would lead me to say that this is a significant PDA. I would consider treating the duct. I'm not going to go into the best method of treating a duct. That's even more controversial. I will tell you, in this particular case, this was from many years ago, the PDA was ligated. But I think now there are many other options, including cath closure, that might be used at our institution instead. But what you can see is after PDA ligation, the NIRS measures are less variable. Look at the renal saturation here in red. It's much higher, even higher than the cerebral sat consistently. And the cerebral sat itself is higher in the over 70% range. On the bedside, on the echo, you see normalization of the descending aortic diastolic flow. So now, of course, PDA is closed and no longer hemodynamically significant. So we look at a different example. Do you think this PDA is significant in this baby based on the NIRS values? This is a 27-weeker, 2 weeks of age. I can show you here at this first time point, at least, the baseline renal sats are reading about 50%. I'll tell you, look, there's a significant variability. So in fact, we thought this duct was significant and this baby received indomethacin. And what you can see really nicely here is an increase in the renal saturation to higher range. I'm sorry, I don't have the two graphs overlapping, but you can tell that the renal sat after treatment with Indocin are much higher than the cerebral sats and less variable. So here's a comparison study. Here's a different baby. And the two graphs are overlaid here. So cerebral sat again in blue, reading in the 70s, renal sats in white, again, kind of in the 70s, but occasionally going up to the high 80s or even 90s. So in this baby, I would feel that the PDA in this child is not hemodynamically significant because of the higher NIRS values. So maybe this baby has a murmur, maybe this is a kid that you could watch or conservatively manage for the time being. Here's another kid who got referred to us for PDA closure. And you can see here, sorry, the image is so poor, but cerebral sats in blue, renal sats much lower in white with a lot of variability. This baby was treated for their PDA. I think this kid got Indocin. And after treatment, again, renal sats much higher in white here and less variable. So even before we got the confirmatory echo, we know that the duct was no longer hemodynamically significant, and we were reassured that this baby was stable enough to transfer back to the referring hospital. Okay, my last slide. Always have to end with limitations to NIRS monitoring, because as much as I love the technology, we have to really be aware of the risks and benefits and limitations to use so that we know how to use it. And I'm a huge advocate for evidence-based practice. There's variability in absolute values between different devices. We have to think about the depth of signal penetration. So as I mentioned, this is limited to the cerebral cortex. So we don't really know what is the oxygenation of the deeper brain structures. And maybe future work will help us to better assess that. Sorry, going back to my first point, I meant to kind of just really focus on, even though there are different devices that have different absolute values, I really like to tell people, let's learn how to use one device well and at your particular institution to make changes. Real estate, so it takes up space on the baby and at the bedside. This was one of the huge barriers when our NIRS was first rolled out in our institution, to get the nurses and the staff to really buy into using NIRS. And once they saw how effective it could be, we were able to make accommodations for it. Of course, there's cost involved. And we really need to focus on additional research for how targeted NIRS monitoring will improve long-term outcomes. So hopefully there'll be studies coming up in the future, which I'm hoping many of you will also be interested in participating in, that focuses on long-term outcomes and targeting appropriate cerebral saturation levels. And then finally, the need for ongoing provider education. So who's paying attention to the numbers anyway? If we're not talking about the NIRS values, it just becomes one other ignored number at the bedside. So it's really important to focus on NIRS use. We talk about it a lot on rounds, for case studies, at presentations like this. So I'm excited to hear if any of you have your own experiences using NIRS monitoring, what particular cases you've used it for. So I think that's all that I have. I wanted to thank our Stanford Neuro NICU team. This is a picture of Stanford University, which unfortunately today there's a huge storm hitting Northern California. So it's not nice and sunny like this anymore, but I'm glad that we are weathering through it, and hopefully you guys can enjoy wherever you are in this new year. Okay, thanks very much. I'm going to stop sharing and open it up to questions.